Rates of depression increased by 52% between 2005 and 2017 among adolescents 12 to 17. Rates of depression increased 63% 2009 to 2017 in people aged 18 to 25. Rate of suicide-related thoughts and outcomes increased by 47% from '08 to '17 among young adults. Suicide rates increased 30% between 2000 and 2018. They declined 2019 to 2020. And suicide is a leading cause of death in the United States. In 2020, 45,979 people died of suicide, which works out to about one death every 11 minutes. So how long have we been here for? We could probably quantify it in multiple suicide deaths. So in 2020, 1.2 million people attempted suicide. What's going on with the rising prevalence of mental illness in our society? This is Dr. Alexander Young. You're a psychiatrist here at UCLA. You are the former interim chair of the Department of Psychiatry and Biobehavioral Sciences, interim director of the Semel Institute for Neuroscience and Human Behavior at UCLA, and you were interim physician-in-chief of the Resnick Neuropsychiatric Hospital. You're also associate director of the Veterans Desert Pacific Merrick Health Sciences or Health Services Institute in the Greater LA Veterans System.
Sounds good.
I just read that. Please don't be impressed. And you have particular focus in community psychiatry, serious mental illness, as well as improving the quality of care to people with mental illness, particularly serious mental illness, but particularly our veteran population. And then you also kind of look at the intersection between mental illness, serious mental illness, and then homelessness.
It's a pleasure to talk to you today.
Yeah.
It's great to have a chance to talk about these topics.
Yeah, thanks so much for coming. I really, really appreciate it. So I think, we clearly have a mental health crisis in the United States, right? I think in 2020, there was an estimated 52.9 million adults aged 18 or older in the United States with any sort of mental illness. And that number represented about 21% of all U.S. adults. Does that sound about right, or is it a lot more?
Yeah, no, that's absolutely true. That's the most common are anxiety disorders. We also, then we have other mood disorders, psychotic disorders, and of course addictive disorders. And there's also some evidence that during the pandemic that number increased.
Right. Yeah. I think the suicide rate significantly increased after the pandemic too. But I think a good place to start is like understanding sort of the underlying neurobiology of mental illness. I think that sets like a really good foundation to then, build all these bigger concepts on. I don't really want to get too in the weeds of it because, mental illness includes like a bunch of different kinds of mental illnesses, right? From PTSD, anxiety, depression, bipolar, schizophrenia especially, right? But can you give us an understanding of the general neurobiology of what's going on in mental illness?
Yes. So, it's, of course, these are brain-based disorders. But they have the unique, they're to a great extent associated also with their, biopsychosocial, so they're brain-based disorders, but they also have, they're also deeply affected by social factors, psychological factors, that sort of functional thing. And we are, of course, there's been an explosion in knowledge of the brain and psychiatric disorders over the past decades. We now have an increasingly good understanding of the genetics, for example, of psychiatric disorders, so substantial genetic components, ranging from some disorders like schizophrenia or bipolar, which are almost half genetic, but then also genetic contributions to things like mood disorders, anxiety disorders, addiction. And then there's been, of course, a great deal of study of the brain. Brain is, of course, comprised of neurons, circuits, systems, transmitters, all these sort of things. And there's been increasing understanding of those also over the past decades. A lot of very exciting research going on.
You said half schizophrenia and bipolar disorder, 50% genetic.
Yeah, so schizophrenia, for example, is about the studies looking at identical twins who are reared away. So basically, when you have identical twins, same genes, or almost the same genes, and who are reared in different environments, Their likelihood of developing schizophrenia, you can compute it based upon the difference, being in a different environment, having the same genes, is about 50% based on their genetics, and about 50%, based on social factors, stresses, other illnesses, that sort of thing.
Yeah. So, and schizophrenia is very familial as well, right? So it's passed down from one person to the next. But I guess the fact that it's 50%, that maybe implies that if your mom had schizophrenia, it doesn't necessarily mean that you're going to have schizophrenia, right?
And it's, so like, for instance, if both your parents have schizophrenia, it's still, you still have the genes. Doesn't mean you're necessarily going to get schizophrenia.
Right.
And it's, the genetics turn out to be phenomenally complicated, like literally hundreds of genes, each of which have a small effect. So it's not like it's sort of typical Mendelian genetics where, one parent has it, 50% chance, that kind of thing.
Right.
Dominant recessive, it doesn't work that way.
Yeah.
But it's sort of like the genetics of height. So height is a substantial genetic component, but there's no gene for height.
Right. So you would say it's sort of an additive effect of maybe all these gene mutations or predispositions via, certain genes, that when those genes are interacted with the environment, potentially produce a disorder or disease such as schizophrenia, such as bipolar disorder.
Yeah, or with substances like cannabis, or with exposures or stresses, or like, various kind of brain traumas, or various, these all create stresses to the system, or, and familial factors, familial stress.
Yeah. What do you think? What do you think of the serotonin deficiency theory to explain depression? This has been something, my understanding, and I'm sure yours is a lot better, is that this is kind of what we thought depression was, right? And especially because SSRI, serotonin reuptake inhibitors, work for depression in some cases, right? So logic would state, right, if you work back from that there's some sort of serotonin deficiency.
Yeah, that was originally hoped that would become the case. It's turned out to be more complicated than that. And
Really?
It's turned out that treatment and cause are not necessarily the same thing. So you can treat something with something that causes changes that may not have been what caused the problem. So people that have depression, again, we know that genetics, interpersonal stresses are particularly important for depression. Life stresses, substances like alcohol, it just turns out that yes, the antidepressants do affect norepinephrine systems, serotonin systems, but it turns out that that's an indirect way they work, because they take time to work, so they cause changes in those systems, which then cause other adaptive changes in the brain that actually improve the disorder.
Right.
So it turns out to be, like many things in mental health, we start with like a fairly simple hypothesis. Hey, we got it. We figured this out.
Right.
And the brain is the brain is the most complicated thing in the universe.
I would say so too. Might be biased though, because I'm always trying to figure out the brain, and I have yet to be able to. Surprise, surprise. What about the network theory? So the network theory, sort of that symptoms of mental illness are connected across diseases, and those symptoms kind of serve as a bridge between them, right? Meaning that there's a lot of overlap between a bunch of these different mental health disorders, like anxiety and PTSD, like depression and bipolar disorder, right? What do you think about that? The fact that, hey, these aren't really distinct diseases, rather it's sort of like just all this milieu, and the way that we diagnose is our attempt at describing and compartmentalizing each of these symptoms.
Yeah, absolutely. So, and this also feeds into the genetic idea. So, again, if schizophrenia is a couple hundred genes for schizophrenia, some of those genes will also increase your likelihood of having other problems. So they're presumably genes for other psychiatric problems. So they're presumably genes for, specific functions in the brain, right? And the brain is composed, of course, of systems. So when we come at psychiatric diagnosis, it's sort of like where we're at still is kind of as if we were diagnosing heart disease by chest pain, right?
Right.
So we you got chest pain, so we're going to try some nitrates or something. We're going to, and that's sort of still where we're at, is we're describing syndromes, and we don't really, we have biological underpinnings, but they're still not the same as the diagnoses that we're using.
What do you think about the fact that psychosis and psychological issues are sort of on a spectrum, right? So, meaning the more issues you have with your genetics, or, the more issues that you have in your environment, it's just a matter of it being on a spectrum with, schizophrenia being over here, and then, maybe anxiety and depression over here. Although, the degree of severity of each varies, right? Where you can have severe anxiety, but nonetheless, it's sort of on this spectrum of psychological disease.
Yeah, I would say that the spectrum probably can be understood in terms of spectrum of syndrome. So psychosis may be like clinical psychosis, like schizophrenia. If someone's in a state hospital or something, may be on one end of a spectrum, and other people on the other end of the spectrum may be creative, more divergent in their thinking. We may call them a little disorganized, you know what I mean, in their thinking or their behavior. And it may be the same. It's a spectrum where, and the reason these illnesses persist, right? So you would expect, Darwinian, you expect people with schizophrenia who, often, much more less likely to have children, would eventually, be pushed out the gene pool. No, because there are it's one of, again, hundreds of brain features or characteristics, some of which are adaptive. It may, you may get people like Vincent van Gogh, or, artists, or creative people, or, people who are, the brain is different, and there's a spectrum for that, and there's a spectrum for mood lability too. There's full bipolar disorder, and then there are people who have, highs and lows, again, changing in emotion, that kind of thing, more sensitive emotionally.
Yeah, that's an excellent point, because a lot of people maybe think that anxiety is a bad thing, but not necessarily, right? Like if you're anxious about getting your work done for, a certain deadline, or anxiety, I have a lot of existential anxiety about what am I going to be able to do and get done and accomplish while I'm here? And it's like really existential and weird, but I mean, nonetheless, like that kind of motivates me and like drives me. And certainly if it gets to a point where, it's getting in the way of my relationships and functionally debilitating, then it's an issue. Then it's pathological. Then I would meet the diagnosis of anxiety potentially, right? But in the meantime,
that's,
help.
Gets you here, right? Gets you thinking, you're prepared.
Yeah.
You come up with agendas for your conversations.
Right. Because I'm terrified of sitting down across from a chair of a department and not knowing what the hell I'm talking about. Yeah. But, and I've always thought of it in the context of anxiety, but you're applying it to the context of schizophrenia, where people more creative, more disorganized thinking, but have other positive attributes. And you mentioned Van Gogh. That's an excellent point.
Yeah, and divergent thinking. So there are different types of thinking, and some people are much more focused and divergent, and they're much more interested maybe in science and like tech stuff, or knobs and bells and computer programming and stuff. And then other people that are more looking for things here and there, pulling things together, right. Thinking more broadly. And it's it's like it's sort of like we have. I think to my mind, we have many different types of intelligence, right? We try and put it in one numerical scale, but the reality is, people are skilled at very particular things.
Yeah. So I want to get to the diagnosis of mental illness. So the DSM-5, right? The DSM-5 is talked about a lot. It's the Diagnostic and Statistical Manual of Mental Disorders, right? And it's the 5th edition. That's why it's called 5. And you would know a lot more about it, but it basically just sets the criteria for each diagnosis of each disorder, right? Mm-hmm. And the diagnosis of each disorder within that criteria has a lot to do with like functional debility, like you mentioned before. But, especially when we're talking about, we talked about before the overlap between a lot of these symptoms, right? Do you think that the DSM-5 provides too rigid of a structure when you're trying to make diagnoses for specific disorders, when in fact there's a lot of overlap and there's a lot of like bridging symptoms potentially?
This is one of the challenges, of course, in diagnosis in psychiatry, is whether to have sort of spectrum type of diagnoses or to have categorical diagnoses. And this, the field over the years has kind of gone back and forth on this one. Every time the DSM comes up, there's people that argue for, well, maybe we should have a spectrum-based approach, and I'm not sure there's a right answer. I think the advantage of having diagnostic buckets that are defined is that people know the syndromes that they're talking about. And so when you talk about giving a medication or something, you sort of know what you're giving it for. Now, having said that, we know that medications are highly variable in how they work. So people with depression, yeah, do antidepressants work? Well, yeah, on average, and in some people definitely, in many people not.
Right.
And so, and what's that about? It's we're clearly not doing a very good job of these categories, but it's, I would say it adds kind of, consistency so that people, I think, most clinicians understand that in real life it's fuzzy.
Yeah.
It's blurry. It's not, it doesn't fit. Individual people don't always fit exactly into these categories.
Earlier diagnosis of mental illness has been shown to improve outcome, right?
Mm-hmm.
The earlier you diagnose it, that means the earlier you can receive therapy and treatment, and people will end up doing better in the long run, right? So what do you think about where we're at right now in terms of the diagnosis, right? We're diagnosing once things are functionally debilitating. We're diagnosing once people are walking into an office in tears because, they want to kill themselves, for example, right? Like, what do you think about finding ways to provide an earlier diagnosis?
Yeah, I think this is critical. It can be difficult to make diagnoses earlier. So like people with schizophrenia, for example, if you look at them a few years ahead of having illness, yeah, you can find differences, but those differences aren't necessarily very specific in terms of where they're going to wind up. So if you take a group of people that have like mild signs of schizophrenia, for example, a few years out, vast majority of them will not go on to develop schizophrenia. Mm-hmm. So it turns out to be difficult to make diagnoses early, but it's critical that we get people early. I think this is particularly important with the suicide epidemic that we're having in this country, because people, and whether it's in many instances, for instance, an illness of something, of despair, deaths of despair, where people, people feel like they're not being valued, they lost their job, the social life, family, that kind of thing, and they don't see it as, and they have psychiatric symptoms, but they don't see it as a problem that's amenable to mental health help. And so, if you can reach out to those people and you can catch them early, the biggest effect in preventing suicide, for example, is to help the people very early reframe this as something that's not them, but something that's amenable to help.
So let me bring up a cool little chart, a cool little graph, right? So this is a model that was that I found that I was introduced, and we'll reference it at the bottom of the YouTube description. But this sort of presents like these early signs and symptoms that eventually progress and bifurcate into specific mental illness syndrome. So on the left we have anxiety syndrome, middle we have mood syndrome, and then on the right we have psychotic syndrome. And it all seems to start with like you have insomnia, there's like energy, and then there's worry, right? There's a couple of these early signs and symptoms. Do you think these are like too non-specific to start, right? And potentially not functionally debilitating to the point where, you wouldn't even be able to intervene early because you don't know which ones are actually going to progress or not?
Well, it's it's good to be linking these things. I would I might reverse some of the arrows. This is what a person experiences. So the person experiences insomnia, and then they may go on to experience these other symptoms. Though it's possible, for instance, that the hallucinations and the other problems are actually causing the insomnia or the depression, for example. It is a bidirectional relationship, so I guess it's complicated. So does depression makes people Sleep worse, yes. And it also appears that sleeping worse can make depression. Sleeping less can make depression worse.
Right. Chicken or the egg
Yeah,
phenomenon.
chicken or the egg.
Yeah. So let me ask you something. Let's say someone begins to have some of these early prodromal symptoms, right? Worry, insomnia. Can't really identify any real reason for it. What would you recommend that they do, right? Like, you can't present to your psychiatrist and say, or maybe you could, hey, I'm having trouble sleeping. Like, well, go to the sleep doctor. There's nothing functionally debilitating with you. You don't meet DSM criteria for such and such, right? Is there anything that they can do on their own, maybe with therapy, that might be prophylactic if they're worried about progressing to something like this?
Right. So it's complicated. The reality is that it's hard to access a mental health professional, right?
Well, yeah, we'll get to that.
So, even if you wanted to get like a psychiatrist input or a psychologist or a therapist, you're going to have trouble doing that.
Yeah.
The reality is that most people turn to someone else, such as their primary care doctor. People that develop mental health problems, like depression, for example, we did a study of one of the first national studies of quality of care for depression, and found that, and this is still true, that fewer than half of people in the United States with depression get any treatment at all. Very few of them have ever seen a mental health professional. Most of them have seen a primary care doctor. To other places also people go is to clergy, to faith-based organizations.
Yeah, sorry. Uh-huh.
And, maybe peer support groups or that type of thing. It's, you can, I would say it's sort of like self-diagnose. The good thing about the internet is that there's a tremendous wealth of information, right? And so you can go to authoritative websites, from Mayo or UCLA or where you can pretty much trust the information.
Right.
And you can get some information that may give you clues about what's going on. And some advice, though, if it's becoming, particularly sort of worrisome or, I think people are concerned where it's going. You really, finding a mental health professional doesn't necessarily have to be a psychiatrist. It can be, a psychologist or even going to your primary care doc who may have, hopefully the primary care doc would say, hey, if you're having sleep troubles, let's get you to a sleep specialist or that kind of thing.
Yeah. So I also think about inflammation as a potential contributor to mental illness. And I always think about this case that I came across. And it was this patient in residency that I diagnosed, not me, but my team diagnosed with NMDA encephalitis. NMDA encephalitis is basically via whatever mechanism, your body develops antibodies to the NMDA receptor in your brain, right? And basically, it's an autoimmune condition where your own immune system is attacking the NMDA receptors in your brain. And the manifestation of this disease is really heavy, like neuropsychiatric, right? So this patient that I treated for diagnosed and treated for NMDA encephalitis, was actually hospitalized in a psychiatric facility for, I think, about a month due to these psychiatric symptoms, right? Because they didn't know what was going on. You do an MRI, it's generally normal. Everything's normal. They're just exhibiting psychiatric symptoms. And I think the movie Brain on Fire, I think, was in this, in regards to this girl that had NMDA encephalitis and sort of her journey. So that is sort of an extreme sense of, how inflammation can actually influence psychiatric behavior, psychological behavior. Do you think there's an element of maybe more subtle inflammation or anything like that contributing?
Well, yeah, and I would say things like that are very exciting. And as I really enjoyed my neurology rotations and stuff, and thought about maybe neurology. It's when you see something like that, you say, "Hey, this is really cool," and because the treatment is also different. I've also had people that came to me with schizophrenia, and it turns out they had lupus, and they have lupus and schizophrenia. And so is that a coincidence? Well, probably not, because like an NMD encephalitis is extraordinarily rare, but it does. If you academic medical center or something, you find it, that's great because you can give someone a treatment that's different and you can send them on a different direction. But there clearly is, there are a lot of, that's an example of the NMDMA receptor involved in psychosis. We know it's involved in psychosis. Antipsychotic medications work there. So the fact that that syndrome produces psychosis is interesting.
Yeah.
And you can also say that with other, other inflammatory illnesses. There's just a lot of interest now in the role that inflammation can play in worsening and causes, the immune system. So, speaking about the brain being incredibly complicated, the immune system is incredibly complicated.
Right.
And it's also highly individualized. Everyone's immune system is different. And you have all, then you have all this gut-brain interaction stuff that's very interesting. Everyone has their own gut flora, right? And so how do you link all these things together?
Right. Yeah. So let's move on because I don't want to get too bogged down because we could be talking about this stuff for like ever, right? But I do want to discuss the contribution of adverse childhood experiences to adult mental illness. They're known as ACEs, right? Adverse childhood experiences, ACEs. And they've shown that having ACEs in childhood actually have like a cumulative association with poor mental health as an adult. They found that you're 4 times more likely to have low mental health satisfaction if you had 4 or more ACEs. Right? And 60% of adults have reported at least 1 ACE in their childhood. Right. So there's a lot of ACEs happening in a lot of people, and it seems like it leads to adverse adult mental health outcomes. What do you think about that?
Yes, I think it's a complicated area, and it's, like many things in psychiatry, it's bidirectional, but it's really important that I think there's increasing awareness about it. So the ACEs survey, for instance, is something that we should be doing with people. Childhood is a really formative period of time. Being exposed to, again, for instance, if you have a parent who kills themselves, right? That puts you at much higher risk of killing yourself because you see it as sort of like an option. Or like it's like that's an outcome, or that's and that's an example of a childhood, very stressful childhood experience, right? People, our childhood stressors, create a post-traumatic stress. People, flash back to or go back to adverse experience that they have. They have expectations. It can cause anxiety. It's also really important to realize that it's not, adverse childhood experiences are not distributed equally in everyone in the population, right? So there are particularly folks from populations that are disadvantaged, lower socioeconomic, less resources, people of color are much more likely to have high levels of adverse experiences in childhood. It's also true that people with parents with addiction, for example, or parents with serious mental illness are going to have very high levels of adverse childhood experiences. Now, how, and how people, what supports people can find as children? How does a child respond when a parent is, addicted, for example, seriously addicted, or has schizophrenia? What does the child do? 2, 4, 6, you turn to the schools if you're a child because the school is a relatively normal place, right? You turn to maybe friends or other family, again, to like the church or something. You may leave the house. And there's, so I think it's just really important. Those are, as a society, in the United States, we have a society that's, I would say it's very individualistic, right? Sort of like people, the sort of zeitgeist or whatever is that people make their own life or something like that, right? I mean, it's like, and you can argue whether or not that's true, but we don't have a very, our sort of our social safety net and our sense of community and that kind of thing is less than many other countries.
Yeah.
And I think it also puts us, it creates, we have a society where, I would suspect we have probably much higher levels of adverse childhood experiences than some other places.
Yeah. And I think that's what we're describing environment, right? We talked about genetics before, and then now we're talking environment. So certainly we're demonstrating that environment also has a pretty significant impact on mental health, right? And the genetic component is also noted because not everyone that has an adverse childhood experience goes on to have issues with their mental health, right? There's got to be some difference there. And also, adverse childhood experiences, or the list of adverse childhood experiences is relatively long, and they're not all equal in severity, right? But they're counting them as adverse childhood experiences. For example, I think divorce, right, is an adverse childhood experience. Having your mom addicted to drugs is also an adverse childhood experience, right? It's like a completely different situation. So I think, that difference is important to note. And then, also, let's not be all doom and gloom, because positive childhood experiences have been associated with decreased adult depression and poor mental health, even in the presence of adverse childhood experiences, right? So
Right.
just because your son or someone had an adverse childhood experience, right? Certainly, it seems like positive childhood experiences might actually be more impactful in that person in the long run than adverse childhood experiences. What do you think?
Yeah, so this is the concept of resilience, which is a fascinating concept.
It is fascinating.
There are, and you see this in soldiers in battle and battlefields also, there are some people who can tolerate enormous stress, right? Who knows why, whatever, again, it's probably genetics, something in their makeup, something like that. And there are other people who just can't. And then there's resilience that's based sort of internally. And then there's also sort of resilience that I think has to do with like supports. Is there someone in your church? Is there someone in your school? Does a teacher sort of, teachers see, right? I mean, they sort of, of course they see the kids and they want to help them out, right? So is the teacher like taking, the child aside or something, or helping them, that kind of thing? You know what I mean?
Yeah.
And clearly there's a lot we can do, and there's a lot people can do. And, genetics are not destiny. That's also one of the, while your genetics shape who you are, they don't make, they don't make who you are.
Right.
So it is possible to, even if you're dealt a bad hand, genetically or adverse childhood experiences, there are ways, and it is possible. Right?
Yeah, I don't know what you've been finding in your practice at the VA, but it seems like not all, but a lot of the military veterans that are coming in with post-traumatic stress disorder after combat have some sort of childhood trauma.
Yeah.
Right? Have you been finding that somewhere?
I think it's certainly, so the people we see at the VA, of course, we see a lot of people with PTSD. So we see a lot of people. So now people that have studied trauma and PTSD, there's different military trauma. There's different levels of trauma. There are scales for it, like 1 to 7. How severe is it? What did you see? What
Right.
did you experience? Is it yourself? It's highly variable. So that, many people will go on to develop PTSD, but not everybody.
Mm-hmm.
So the people we see there are some levels of trauma where everyone will develop PTSD, but for the generally trauma that people experience in the battlefield, like explosions, that kind of thing, IEDs in the recent conflicts, we will see those folks. Certainly I think it's one thing that's, coming into the military with more adverse childhood experiences, less in a sense of interpersonal kind of resilience and resources and that kind of thing, certainly makes a difference.
Do you think the military should be looking at and quantifying adverse childhood experiences in their enlisted folks? Should that be a consideration?
I think it's really important. People would, in the military too, they try and screen and assess people on the way in to see who's not going to be able to tolerate basically the stress of combat, right?
Got it, yeah.
And then they place them into boot camp or Camp Lejeune or whatever, put them under high degrees of stress, and then see how they function.
Mm-hmm.
I think with the idea of sort of weeding out people who are just not, it's going to be just really, really bad for them to be in a high stress situation, or they move them out on a different job. It's for the military, it's challenging now because we have an all-volunteer force, right? And so you may not be old enough. I'm old enough to remember when there was a draft,
Mm-hmm.
right? So draft, well, yeah, a lot of people got out of it, people money, that kind of thing. But you also had a much larger pool to deal with. And currently there's a lot of pressure people say we need more in the people in the armed forces, particularly when we're in combat. And so there's a lot of pressure on the military to take people who, if they had their druthers, they might think, well, you might be better off not being exposed to a combat situation.
Yeah, but I don't think boot camp is an actual replication of the process of developing PTSD, though, right? Like PTSD doesn't happen like the next day, the following day, or even in some cases like 2 weeks, 3 weeks, a month, right? This is a process that develops over a pretty long time period. And does boot camp actually replicate who's going to develop PTSD or not?
Yeah, I don't know. The military might know the answer to that. I don't know the answer to that. I'm not sure they tell people that. I'd say predicting PTSD would be great. If you could identify someone and look at their sort of chances, their sort of, in a sense, their resilience, their susceptibility to stress, whether it's adverse childhood experiences, genetics, other psychiatric problems, and then do some type of prediction of how they're going to function in combat, I think that would be great. I haven't seen models for PTSD that are terribly effective in terms of identifying people.
Yeah.
It would be, certainly it would be great if we can get there.
Yeah. Let's talk about the increasing rate of mental illness in the general population. So rates of depression increased by 52% between 2005 and 2017 among adolescents 12 to 17. Rates of depression increased 63%, 2009 to 2017 in people aged 18 to 25. Rate of suicide-related thoughts and outcomes increased by 47% from 08 to 017 among young adults. Suicide rates increased 30% between 2000 and 2018. They declined 2019 to 2020. And suicide is a leading cause of death in the United States. In 2020, 45,979 people died of suicide, which works out to about one death every 11 minutes. So how long have we been here for? We could probably quantify it in multiple suicide deaths. So in 2020, 1.2 million people attempted suicide. What's going on with the rising prevalence of mental illness in our society?
It's an excellent question. I would say, I think we need to think about probably it in terms of different mental illnesses and each one of them, in a sense, why it's happening. Mm-hmm. We could start anywhere. Again, like the prevalence of schizophrenia, bipolar disorder. I'm not sure that's changing necessarily.
I think
a lot.
I think that's remaining the
So it is very hard. Having said that, our data on these things is not great, right? So our data on the exact prevalence of these disorders, we have estimates. It's sort of hard to get the exact prevalence, particularly of schizophrenia, bipolar disorder, but even things like suicide. I mean, suicide has been very highly stigmatized in the past. It still is. In the past, many people, like coroners and stuff, would not attribute their death to suicide, right? Because it causes all types of problems in a religious society, in the family, and so forth. So there's some of it is even for that, which you should figure is like something we should definitely be able to count. Our counts may not be exactly as they seem. So if we were to pick one of them, you could pick deaths due to drug addiction, for example. Mm-hmm. So we're of course seeing, there was the opiate epidemic. So opiates being, of course, a substance that is fatal in overdose. There was the opiate epidemic, which then, prompted an enormous number of changes to try and reduce the opiates. And now we have a fentanyl problem because it turns out fentanyl is just, this is a market, and the people that are selling fentanyl just turns out to be, cheap, easy, large mass production, ship it in from overseas, that kind of thing. And so now we have a crisis of fentanyl deaths in this country.
Right.
And in terms of suicide,
I just use suicide because I think it's sort of like the extreme sense of mental health crisis.
Right.
Right. It's just easy to quantify, right? And it's going up. And I mean, I'd have to push back a little bit with the notion that, they just weren't counted back then because it was stigmatized versus now. Again, you probably have a better look at it because you're a community psychiatrist especially. But I just use suicide because it's like an extreme sense and it's quantifiable.
Yeah. And no, I mean, clearly most of it is that there is really an increase in suicide in our country over the past years. And, suicide is interesting because it's a behavior, right? So it's a person making a decision to end their life, and and how that, a certain amount of that is, what I call sort of like labile decision making, right? Sort of like, intoxicated, something, having a really bad day. So, again, acute stressor. Your wife had an affair or something like that, right? And or you just you lost your job, or you're about to be evicted. So there are these sort of signature high stress points where hopefully we can get people through those and get them to see the other side. But there is this overall kind of, you have to, in something like suicide, people tend to label it as a psychiatric problem, but I think that's somewhat problematic. I mean, do people, when they're about to kill themselves, are they depressed? Yeah. But is the depression the reason that they got there? Usually no. It's something else. It's like, again, we have, large groups of working class people in this country whose livelihoods have really been and continued to be, seriously affected by job prospects, addiction and substances in communities, that kind of thing. And, that's where sort of the notion of deaths of despair comes out, that, people are just feeling like, well, I used to have this and that. I used to have, a good job and stuff, and, paid reasonably well. I could afford housing, take care of my kids, that kind of thing. I used to have a family unit, maybe church, community. And now all those things are, it's gone. And I just don't see, I can't take care of my family, right? And just sort of this whole notion of, so I think we need to, suicide is it's a tough one, but it's one that we really need to examine as a society. So it's interesting. There are other countries, so like Denmark, which I visited recently. Denmark used to have one of the highest suicide rates in the world. And they're a country that's far northern Europe, so the winters are dark and long and cold. And it's sort of can be very isolating. So they had a national campaign where they worked on things like social connection, social supports, reaching out to people, helping people in need, identifying people that were going through, crises and, on their own, and their suicide rates plummeted,
That's interesting because you mentioned connection.
Yeah.
And Denmark is a relatively homogenous country, right? Whereas the United States isn't, right? So I do wonder the polarization potentially in our country, the further polarization in our country that continues day after day after day, the lack of connectedness, the lack of community, maybe that's a contributor.
Oh, I think certainly. I mean, I think it's for suicide, I think it's critical. It's very troubling where we are as a nation in terms of sort of demonization of other people, you know what I mean? And the whole social media thing, which we'll probably get to talk about,
That's next,
and the sort of echo chamber stuff,
right?
Like like half of the country is evil. I mean, it's sort of increasingly we see, we have half the country here that's, looking out for each other, doing the right thing, and then we have half of the country that's just evil, right? And it's just sort of like the messaging, and I think it, to really do something about suicide, we're really going to have to adopt more like the social approach, like the Denmark approach or something, which is, that's like no one left behind, right? And, whether what community, what race, what age, where you are, that you're not alone. And yeah, I mean, it's worrisome because in our country, the way it's going, it's a little hard to imagine that happening.
Yeah. I always think about suicide is so interesting to me because I always think about, that our higher cognitive functions are probably both a blessing to get us out of the lunch hierarchy, right? But at the same time, it seems like it's probably a curse because I always imagine, say I'm out on the Serengeti, right? And I'm a person and I'm observing different animals. And, the main way that this animal gets killed is it gets killed by a lion or something. But then a big group of them, a big proportion of them are just jumping off cliffs. And it's just like, no reason. They're just jumping off cliffs. That would blow my mind, right? If you were actually watching that happen. But we see it in our society and we see it in our community, and it's with like people, right? With brothers, sisters, family members.
No, I think people...
And it's just, it doesn't resonate the same way.
I think we increasingly leave people kind of behind in our society. You look at like the street homeless and that kind of thing, and people's increasing tolerance for that. But I think in this discussion, we should have our little warning or something, which is, there's the 988, right, which is the new crisis line.
Absolutely.
If you're having thoughts of harm or harming yourself, call.
Yeah. We'll put it up on the screen.
There are people who are working hard on the other end of those lines.
Yeah.
Reach out. You don't go this alone.
Yeah. And you mentioned social media. Let me bring up something for you to look at. All right.
And we're going to be on social media with this, or?
Yeah, this will be promoted on social media. Get off social media while you watch us on social media. All right. So this is a graph. Bottom is year. Top is suicide rates per 1 million girls. And the top line is girls aged 15 to 19. The bottom line is girls aged 10 to 14. And that white line in the middle is where social media meets, or social media becomes available on your mobile phone. And from that time period, I think it says 2008 down there, there's a 70% increase in girls aged 15 to 19 in their suicide rate, and there is a 151% increase in the suicide rate in girls aged 10 to 14. I know you mentioned before that, doesn't necessarily mean causation. Association doesn't mean causation. But you got to look at this graph and say, this is striking.
Yeah, I think when there are, right, it's hard to know. There may be other things in society that are going on at the same time. But I think people increasingly realize that there is something going on with social media that's not good, particularly in these age groups around self-image, self-worth. We saw the recent testimony by the Facebook executive or the Instagram executive to the House. Facebook, Instagram, now it's TikTok, I guess, right? Which I personally have a really hard time tolerating TikTok.
Are you on TikTok?
No.
No, me neither.
Because I can't. Maybe that's the sign I'm older or something. I just can't.
Right.
But in these age groups, that's it, right?
That's it. Yeah.
And I think it's very concerning. And it's tough. Again, I think as a society, again, the House and the Senate seem to be briefly interested in this. These are corporations that are enormous. Just sort of value and profits, right?
Right.
Incredibly wealthy, incredibly powerful. These are United States corporations out of California, I might add,
right.
Which are going to the States and to the world. And this is, but the research that's been done suggests this is true. And again, these companies certainly have data on this, or they could easily get it. It's remarkable how much data they have about people. It can be, if you knew how much data Facebook or so do you use one of those channels?
Instagram.
Instagram. Okay, so you're in the Instagram. I'm probably more like the Facebook generation or something.
Right.
Right. But they know, and because of all the data they can aggregate about you, they know all about you.
Right.
Because they can pull in. There are all these data aggregators behind the scenes in the United States pulling data from a million sources, figuring out who you are and which you are, and they can they have basically a long list. They can describe you probably really well, and they know what to feed you, and they have algorithms and so forth. And of course, TikTok is the new thing, and the algorithms are to, as you probably know, to feed you content that produces an emotional response in you. It's like marketing, right? And it can be a good or a negative emotional response from a marketer's perspective. It's like sales, marketing, commercials. The goal of a commercial is to make an emotional connection in you between a product and something else. Now, usually that would be like a positive connection, right? You wouldn't want a negative connection. But in a social media thing, if making people feel worse about their physical appearance makes them use your app more and look at more pictures, that's what the algorithm is going to feed you.
Right. So now let's talk about the military veterans particularly. The number of suicides in 2019 was 17.2. And it was the rate of suicide in veterans was 52.3% greater than for non-veteran U.S. adults. What's going on with our mental health crisis, specifically in the military veteran population? Some people that have, sacrificed so much for us, put their lives on the line, they come back home, and it doesn't seem like they're much safer back home than they were abroad.
Yeah, it's a very challenging issue. And the research that's been done on sort of predicting suicide suggests that a substantial amount of the risk for suicide in these people may actually have existed before they entered the service. So it's not only the stress of being in the military, but it's again this issue of who are we recruiting into the military, right? People these days, volunteer Army, often come into the military because their job prospects may not be great. They may not have a social support or so forth. Out in the home, they may have challenging social situation, and that brings them into the military. So they are a vulnerable population or an at-risk population coming in, and then we expose them, worst case scenario, to trauma of combat. Hopefully these days we don't have. I guess we're in one of these brief periods in the United States where we're not actually fighting a war directly.
Not directly.
Seems like that, but the history would argue that this is going to happen again soon.
Right.
It's whatever reason in the United States we're very quick to military conflict. So, so what's happening to these people, and why are we not reaching them? The VA is working really hard to, again, it's really hard to provide these sort of wraparound services that are necessary, and the supports and the social supports. It's really important to understand that this is a medical problem, yes, but it's more than a medical problem. It's also a social problem and a community problem. And again, we have people that are with homelessness, addiction, people that may not have strong social support system. The VA is actually provides a much more robust mental health service capacity than exists outside the VA. So there are more resources. The VA pays a lot of attention to these issues like housing, assertive outreach to homeless people, mental health treatment, treatment for addiction, actually more than happens outside the VA. But, and could the VA do more? Sure, but the VA they've done a lot of sort of cool things to try and get ahead of this. So for instance, they've come up with big data approaches to identifying risks for suicide. So the VA, 7 million of our veterans about touch the VA every year, VA healthcare system, out of about 25 million there are. So many are not. But, and the ones that do tend to be the ones with less access to like private insurance or work-based insurance or that kind of thing. So the ones who are more needy, more vulnerable, and also more recently served. So they, for instance, they have a big data approach where they take all the data available about individuals in their data systems and do, analytic approaches to identify a population of people who appear to be at high risk. And then they reach out to them. They have suicide coordinators, suicide prevention coordinators from around the country who make phone calls, reach out, work to engage with people. So the VA is doing a lot, but it's a population that is, it's sort of, it's all of our responsibility. It's not just the VA's responsibility,
Right.
I guess is what I'm saying.
Yeah.
It's all of our responsibility to help these people and help them get through where they're at, and we can't lose, whether it's, so for instance, you saw Jon Stewart and the burn pit stuff recently and so forth. We just have to, it's sort of everyone's responsibility to figure out what we can do to help these folks.
Right, but why? But at the end of the day, still, why is the suicide rate so much higher? You're saying, maybe they were predisposed before the military service. Okay, they have more service than someone else in their shoes because
Yep.
they're military veterans. Yet their suicide rate is 52% higher. Like what?
Well,
what is
I think
causing that?
it's those two things that are accounting for it. That a high risk situation, socioeconomically and developmentally and support wise, and adverse child experiences and all those things coming in, and then layering on that top of the trauma, and then having and then maybe having a hard time reintegrating right into society, entering into a society also where the chances of folks for gainful employment and good jobs, neighborhoods they can afford, the same people that working people everywhere in this country face now, is that population is facing it. And because that population is more sort of enhanced for those things and less well prepared in some senses, just makes them at really high risk.
If you had all the money in the world, all the resources in the world, what would you do tomorrow to be able to help the military veterans and their suicide rate and all their issues? If you could give them anything, what is it that you would give them?
I think I would give them housing, gainful employment, training if necessary for gainful employment, paths towards work, meaningful work.
What do you mean when you say meaningful work? What's that distinction? Because that's an interesting term. I keep seeing that term: purpose, meaning, meaningful work.
Yeah. So, like a job on TaskRabbit or something, right? Where, you're doing here or there and making sense. I don't think that's not terribly meaningful work. But it's it's some job, even a construction job, right? Or construction or repair or, those are jobs where it's like an identity and it's something you can be good at, and that people can work at, and it's helpful and they're helping people.
Yeah.
And so, that's for, construction or, it used to be factory jobs, building stuff, making stuff. Now it could be something in computers,
Right.
or technology, and there are training around that. And then there's also I think also the other thing I would say is just sort of the outreach in a sense. It can be hard to reach people, but again, how do we reestablish this sense of community? Whether and that's what vet centers do that sometimes for veterans. But how do we, again, how do we not ignore people?
Right. And then, do you think the military is doing enough for the veterans during active duty?
I don't work in the military, so the question is, it's a great one. If you start to see signs of PTSD or traumatic stress or something, or if you have getting back to TBI or something, right, or to concussion, again, like in football and things, all the stuff says if you have one concussion or something, you should like pull them out, right?
Right.
You know, there's a vulnerable period. You don't want to put concussion on top of concussion. And are they tracking that kind of thing? You know, stress and so forth. And I don't know the answer to that.
Let's talk about mental illness in
Yeah.
healthcare professionals. So I'll start with an anecdotal story of myself. I suffered from depression in residency. It was interesting because, you know, I think there's a lot of different factors, and, you know, whether I was genetically predisposed to depression or whatever, you know, that's neither here nor there. But I think that the medical field, particularly in residency, really provides, it really is a very unique circumstance in a couple of different things that I was really able to identify as potential contributing factors to my own depression. And another colleague, another resident, also suffered from I ended up also suffering from depression. And then I think around that same year, there was a fellow or a resident that jumped off the roof of a hospital in New York and committed suicide. So the factors that I found were, first off, you're so tired all the time, right? You're sleep deprived. And like you mentioned, that can exacerbate depression, right? And then you have this magnifying glass on you because you're constantly being assessed. So you're tired, you're messing up. And, you know, in my case, I was depressed. So that was sort of having a positive feedback loop in and of itself, right? I would mess up more. I was more depressed, more tired. And then that would cause them to be even more critical of me, right? I mean, there should be an element of resilience there, certainly, but I just got stuck in that loop. And then also, I think in residency, you're a doctor in practice, right? So you're so adjacent to really big existential concepts, right? Or at least I was, and how I was reacting to them, I was like death, right? Like a patient, like you said, like dying on your watch, thinking back on the kind of things that you could have done. And you're so adjacent to that, and you're asking all these questions of yourself. And I was doing it in the same exact time where, you know, I'm depressed and I'm in all these other things, you know, and I'm tired, right? So it's just like this really big mix of just like all these different things pulling me in so many different directions. I could never just ground myself and just have like my feet under me, you know? And then I think the environment that I was in also, the third thing I think is the environment that I was in just wasn't a supportive one for mental health. And I don't know how it is now for residents or, you know, on this side of the country. But an interesting example was I'm walking around in clinic, right? And one of the doctors that is supposed to sort of be looking after the residents, right, pulls me into a clinic room and says, let me talk to you for a second. So I'm like, okay, like this is the moment, right? This is the moment where this guy asked me, am I okay? Am I not? And when I tell him that I'm not, right? And he looks at me and he says, I want you to tell me the truth. Are you on drugs?
Yeah, right.
Right? And it was like, it was more disappointment than anything else, you know? It was just like, I'm not on drugs. I just probably meet the diagnostic criteria for depression right now, you know? So, but that was just like an example of sort of the environment that I was in at the time. But, you know, nonetheless, I had really great support, like you mentioned before, from family members once I reached out to them and stuff like that, and friends, and they really, really got me through it, and I'm so thankful for them, and I'm a lot better now. But, you know, throw that into like COVID right now, right? A lot of mental stress for a lot of healthcare professionals. Have you found the same? Or?
Yeah, and if we can, you know, I guess back in the theme of, you know, supporting people through, you know, medical school and residency, which are clearly can be very stressful experiences, as is the experience of being a physician. So sort of full disclosure, UCLA has a behavioral wellness center, which is mental health supports for trainees. For example, medical students, residents, fellows. Full disclosure, my wife is the director, so you can have her on at some point in time.
Yeah, totally.
She would like to talk. This is her passion, is this topic.
Sure.
It's something that we need. So medicine is moving more towards organized medicine, right? Sort of, I think, as it used to be, we had a sort of culture in medicine where we're sort of all in it alone, and, you know, set up your little private practice and stuff. And now we're pretty much all of us are going to be working for large healthcare organizations, all of us physicians. Most of them are now. It's been a major sea change, and it's even more so going to be in the next few years. So it's pretty much everyone. And so now we have a system where, pros and cons of that. But one of the it is possible to embed resources in these large organizations for detection, outreach, supports, that kind of thing. And I don't want to, if you're not comfortable talking with this, that's fine. But I don't know if you have thoughts on, and we can get to the COVID issue, but sort of, many people have been in your experience in residency, right? Mm-hmm. And sort of how you got through this, or was it, clearly it got, you got what you needed, right?
Yeah, I did. And interestingly, I'll admit it, man, I called my mama. I called my mom, and, I told her what I was going through. And like a lot of people don't have that luxury, right? They can't just call their parents and talk to them about what they're going through, and she was able to make the appropriate appointments for me. And I went and I saw the person I needed to see, and then, got through it, right? Like, and then after that, it was like constant check-ins from my family and like constant check-ins from my friends and stuff like that. So, which really helped me get through it, right?
So it's your family, right?
Family and support. And interestingly, my colleague that ended up also having depression, it's so interesting, man, because I got through my thing, and then I started seeing this guy, and the telltale signs of some mental health issues, like start showing up late to 8 a.m. Morning presentation, right? Start showing up late disheveled to 8 a.m. morning presentation, right? Starts messing up. People start talking about him messing up, with notes and stuff. And it's the same exact thing that happened to me. So then I went to him and I said, what I wish someone would have done to me, right? Yeah. Which was, you okay? Are you all right? And then sure enough, he spilled his guts to me, because I'm sure he was dying to do it, because I was too. So then I gave him the contact of someone that he saw. And then within and I checked in on him pretty frequently, and within a couple months, he had gotten through it, and it was a lot better. So it just that different perspective was just so interesting for me to be able to actually witness that.
Yeah, it's it's sort of the hero culture of medicine, right?
Yeah.
Again, we're all kind of heroes. We're on our own. We should be able to do this. We have to be able to do this, and it's it's just the issue of burnout. Burnout rates in physician groups are very high now, and certainly COVID was, it's been a very stressful time for everybody, but for medical professionals and for doctors, nurses, everyone that both in terms of seeing people die, right, and seeing people loss, and families not being able to be together at loss. It's been, and also just the medicine. People generally go into medicine for a sense of for actual to practice, right? You know what I mean? It's sort of, you actually want to help people. I know this sounds kind of corny, but, you actually want to, and this is sort of the reason I went into psychiatry, was because I actually genuinely believed I could help people. I could take people in a situation. There are things I could do that other people weren't doing or weren't available, and that I could make a difference in their life.
Right.
And increasingly, the practice of medicine is less that. Right, and more kind of, charting and stuff. You see patients, right? Your inbox or whatever it is,
Yeah.
And this sort of a lot of the sense of gratification in medicine is not, is a little harder to come by.
Yeah, we could talk all day about this stuff, especially in the context of COVID. But what about mental illness after brain injury, after concussion, after traumatic brain injury? Got to talk about that, because brain support program, that's what we deal with. And a history of anxiety, or really any mental health disorder, is a predisposing factor in persistent symptoms after you've had a concussion, right? So certainly we're seeing this growing mental health issue, and that translates to now this growing number of patients that we're having that are having persistent symptoms after their concussion
Yeah.
time period. And a lot of them, like, they have their concussion and then everything gets a lot worse, right? Their anxiety gets a lot worse, their depression, their schizophrenia potentially, right? If a schizophrenic has a concussion. What's the right approach there? Is it a matter of treating it as is? Is there a different treatment approach that we should be having, or what do you think?
Yeah, and it's also, and there's concussions and there's also traumatic brain injury, right? And so if you have a traumatic brain injury, clearly you can, on a brain-based basis, I have people that appear to have a stroke in their 40s or something and develop schizophrenia, right? Because it's just like a stroke in the wrong place.
Right.
You know what I mean? So if, brain injury can, because these are brain-based disorders, can, literally provoke a psychiatric illness on the
Right.
basis of brain damage.
Yeah.
In terms of how to manage people with concussion, this is an area where I think the VA is probably the one of the leading, organizations in this area. And I think the most important thing is to, we tend to get focused, and this happens on whenever people have multiple disorders, like when people have like a psychiatric disorder and addiction. We try and sort of, pin one or the other, right? Sort of like, well, stop using those drugs, and we're not going to treat your psychiatric problem until you stop using those drugs.
Mm-hmm.
Or, get better for the psychiatric problem. We're not going to treat your addiction until you get better from the psychiatric problem.
Yeah.
And so I'd say with concussion, it's sort of like the same thing. We have to treat everything. You know
Yeah.
what I mean? So, and these may be, maybe these are time-limited things, some of them. The treatments are, and so, we talked a fair amount about medication, but it's important to realize that also psychotherapy and counseling are really, really effective treatments for psychiatric problems. Sometimes they're more effective than medication.
Let me interrupt you
Yeah.
there. How does therapy on a brain neurobiological basis actually work? Because people just think it's like, I just go talk about my problems and then I can talk about my problems, so I'm more comfortable with myself, so I feel better. There's certainly an underlying neurobiological thing that's happening when you're
Yeah.
participating in therapy. Can you maybe describe that real quick?
Yeah, so it's sort of, so for example, when you give people medications, you can see, if you do scans and so forth, you can see changes in brain functioning. So the brain, of course, you got the neurons and you got the receptors and you electrical transmission and so forth, but you can identify changes due to medication, and you can actually identify changes in brain functioning due to psychotherapy, which shouldn't be surprising because, the brain is behavior, right? Where else does it come from? It's
Yeah.
not like out there.
Out
So
in the ether,
clearly,
right, yeah.
clearly psychotherapy is producing change in the brain. And it does. It's something that, you think like treatment for psychiatric disorders is hard to come by. Psychotherapy is particularly hard to come by.
Yeah.
And like cognitive behavioral therapy, which we talked a little about before, very effective. Try and find someone that provides cognitive behavioral therapy.
Yeah. So
It's really hard to do.
You would say very important after, because people that come into us after a brain injury, they've sort of developed a maladaptive way of dealing with their symptoms and with these concussions, and certainly the psychological component plays a huge role to their symptoms that they're coming in with, right? So you would say if you're not doing therapy, you should be doing therapy at the very least after a concussion if you're having persistent symptoms.
I would say, and this is something that, yes, and this is also true for long COVID or other sort of persistent, behavioral problems. And, should you take the medications that are necessary to treat the symptoms they're having? Yeah, sure. But, it's not, there may be more that's necessary, and there may be areas where the, cognitive behavioral therapy can be really helpful in terms of improving. It's sort of like cardiac rehab, right? Person increasingly has like a heart attack or something that's serious and disabling. Increasingly they are thought to need cardiac rehabilitation, right? And it's sort of like which is, a fair amount of that is sort of psychotherapy, right?
Right.
And whatever they want to call it. And
Yeah.
it's, I think it's a similar thing with a concussion. We have to, Or like sleep. We talked about sleep before. Cognitive behavioral therapy for insomnia is highly effective. It really, and in a sense, it may be a better treatment than medication.
Yeah.
You know?
Let's talk about mental illness after an athlete retires from sport, because it's something that we see a lot, right? Especially in the football guys, right? Like they have a history of head injury, but then they're also having like some mental health issues, right? Could it be related to the history of repetitive head trauma? Certainly, right? But there could also be a contribution of just the toll on your mental health of transitioning out from a routine, a sport that you've known your entire life, into retirement.
Right.
And they actually did a cross-sectional study, and they found the biggest factors involved in developing mental health after retirement from sport is an involuntary discontinuation of the sport and no transition plan prior to discontinuation. Both of those were associated with greater depressive and anxiety symptom severities. What do you think?
This is like the Dwayne "The Rock" Johnson story or something like that, right?
Right.
He was,
Right. Yeah.
he was a football player. Or like, this is what they call the NFL is facetiously referred to as not for long. That it's an all-encompassing, it's your whole life, complete dedication to it, and then it's just done.
Yeah.
Right? And same for like football, like college football. We have, a lot of amazing, really impressive athletes. How many of them are going to be in the NFL? Not very many.
Right.
And
right.
so, and there's certainly not very many for long.
Yeah.
And so, I think it's we have to, it's one of these, sort of despairing transitional periods. It's sort of like, when Dwayne Johnson talks about it, he was sort of like, well, he became at some point aware to the fact that he was not going to be a football player anymore, right?
Yeah.
And
Yeah.
it was not his choice. He wanted to do it, but there was no work there.
Right. Yeah. I'm a huge advocate for providing these guys therapy or the access to therapy before they retire, right? So they have touch points already with a therapist, right? And then also for a plan, right? What are you going to do after, like constantly hammering that home of like, what are you doing afterwards? What are you doing afterwards, right?
Right.
Even in the guys that might have a longer career, right? What's injury going to do, right? What's all these other things going to do?
Yeah, and it's football is a particularly, I don't know how to describe it, like intense sport, right? Really all-encompassing, and where's that energy going to go?
Yeah, and that leads me to my next point, which do you feel that there's attributes in football or in other sports that are mental, right? That will benefit someone in their sport of football, right? But might be detrimental, in retired life, right?
Yeah.
And you could say the same thing about the military veterans, right? Certainly, right? You're not acting the same way. You shouldn't be acting the same way in an active war zone as in, just
Right.
regular life.
Well, in football, for example, I was never, whatever, played football on my own or whatever with kids, but never a football player. But my read is that a fair amount of football is getting yourself psyched up. So like getting yourself like, it's a sport, and, I got a sense of this when I would like dabble in it. It's like 100% sport. It's like a sport where there's someone else over there. You're playing 100%. And if
Right.
if you're not 100%, they talk about 105, but there's no 105. If you're not 100%, you're not going to make it. If you're 99%, it's not going to happen.
Right.
And so, and so football players, for instance, make themselves angry, or maybe they have anger issues or issues with anger going in.
Right.
And they use that. And on the football field, that's highly productive.
Right.
If you're like furious,
Yeah.
you can get to 100%,
Yeah.
right? But
Yeah.
when you get out, probably not so much.
Right. Yeah. Yeah. You hear about some of the guys like, the domestic violence and like stuff
Yeah.
like that.
Right.
I wonder how much of that plays into that kind of behavior afterwards or even during.
Yeah. Well, it's violence, right?
Yeah.
Football is a violent sport.
Yeah. Now, what do you think about the contribution of chronic pain to mental illness? So a lot of these guys, they're in chronic pain, right?
Right.
And that's why a lot of them, self-medicate and, stuff like that. But then also there's an element of that contributing to people's mental health. I have had lower back pain. I pulled my back boxing. Man, I've had back pain for 2 weeks, and I'm getting anxious. not being able
Like
to
now?
not being able to do it. Not now. No,
Okay.
no, I'm chill. No, I'm pretty cool. But the fact that I haven't been able to just participate in
Yeah.
punching a bag or exercising or anything like that is like just really gotten to me. So and that's just like pulling my lower back muscle or something. I can only imagine some of the pain that these guys are in on a constant basis.
Well, I was going to pull out the same example. So I have had back problems in the past, and you have to sort of have it to realize the emotional impact of a pain like that.
Yeah.
Like, with back spasms or something, you don't know if you're going to be able to stand or stay standing. You know what I mean? And the pain is just overwhelming.
Yeah.
It's just sort of, it's like your whole body, it's your whole psyche, and it's emotionally, it can have terrible consequences. Depression, anxiety. Anxiety. I'm not going. Can I actually do this? Because this is. I don't know when the pain's going to come on. Depression. I can't get through this. And so pain is it's interesting. Pain, of course, cognitive behavioral therapy works for pain. And pain is all wrapped up in pain medication, the Percocets and so forth, and particularly back pain,
Right.
which is a particular type of pain that doesn't really respond to medication terribly well.
Yeah.
And doesn't, and the treatment, doesn't respond to surgery, though a lot of it is done, doesn't respond to medication, though a lot of it is used. And what does it respond to? It responds to physical therapy, and cognitive behavioral therapy.
Right. Yeah. And maybe alternative treatments.
And
Self-medication with cannabis. You have a lot of people doing that. A lot of the football guys, at least. And we can talk about, we actually already talked about the potential long-term mental health issues with chronic cannabis use. It can, in the short term, acutely help with the mental health stuff, like a panic attack or something, right? Or it can worsen it. But in the long run, it tends to worsen depression and anxiety and a lot of those other symptoms.
Yeah, cannabis is complicated. It's something that we really need to be thinking about a lot more because, of course, now that it's sort of quasi-legal in most of the country or, majority of states in the United States,
Yeah.
The rates of use are just going way up.
Yeah.
And cannabis is interesting. One of the effects that cannabis has is it has a negative effect on cognitive capacity.
Right.
Both while you're using it and if you're a heavy user, there seems to be some persistence of that.
Yeah. So we talked about that on the last episode, but it seems like discontinuation recovers a lot of that cognitive.
Yeah. Well, it's
deficit.
and it's discontinuation, meaning you can detect cognitive problems for like a week.
Right.
Like,
a week. Yeah.
So if you think you're like using on Friday and having a test on Monday, and you think you're going to do as well, you're fooling yourself.
Right. Exactly. Yeah.
That's just a word to the students. The other word I would say is that cannabis is a teratogen, so it causes birth defects as well. So the things that people don't tend to think about in its use is that it has some harms. I mean, clearly people are going to use it more, but we need to think seriously about what some of the harms are too.
Yeah. Let's talk about some other treatments. We already talked about SSRIs and some of these standard of care treatments and how they work. We talked about therapy, right? Especially cognitive behavioral therapy that can actually be brain changes similar to the ones that are seen with just regular standard of care medication, right? What do you think about the role of exercise? Exercise has been shown to be protective for a lot of mental health issues, right?
Oh, absolutely. It's exercise is really good for mental health for probably across most mental health disorders, anxiety disorders, even disorders like schizophrenia get better with exercise. Exercise is clearly beneficial for depression. Like aerobic exercise, cardiovascular exercise. And though the effect only lasts for a couple days, and I mean, of course, you seem like you probably work out, right? So you get
Thank
exercise.
you.
Yeah?
I haven't worked out in a while because of lower back pain, but I like to think.
Well, all right. Well, we'll get you more physical therapy. And
Maybe I can
back.
jump on this bike behind me when we're done, or during, or right now.
It basic depression. I mean, exercise and runners. For a couple days you feel better, right?
Yeah.
That's better if it's for mood, energy, all those things.
Yeah. What do you think's actually going on that's improving the mood? I know it's probably a lot of things. We talk about the runner's high, but what do you think is actually happening?
Well, it was back in the 80s, like it was like the endorphins, right? Isn't that what people were talking
Yeah,
about?
yeah.
I don't, it's an interesting question. I don't think people necessarily know because it's something clearly in the brain or the nervous system, right? So you do get, of course, improvements in stamina and so forth, but they don't track with the improvements in mood because the improvements in mood are, of course, a day or two. So it's something about, I guess you can think evolutionarily about, something about having gotten the exercise and the cardiovascular work that just plain is helpful in the brain.
It makes you
right?
feel good.
Yeah,
That's
it's
all
a
that
great
matters.
area for study. I don't know.
Yeah.
I haven't seen I'm not sure what the research is
Yeah.
on that, but
But I mean, would you recommend it for anyone suffering from depression or instituting as a plan of treatment for someone that comes in with, let's say, after a concussion, having mental health issues, or even not, right? Just having mental health issues.
oh yeah, absolutely. So I mean, that's and we did a project, for instance, trying to improve weight in people with serious mental illness, and any type of weight, or many people have done studies like that, or efforts to improve in people with mental health problems, improve. You want to improve both diet and exercise because it has very real effects on physical health, but it also has real emotional effects. Now it's, as a physician, I recommend that to almost everyone, and how many people actually do it?
Right.
I mean, close to none. But
Yeah.
I mean, at least I don't feel like I'm making a big difference. But yeah, I mean, if you can get people, I mean, pretty much, if you can get people, out of the house, active, socializing, and the same goes for work too. I mean, work is for most people is emotionally, it's good for you. It's emotionally, it's good for you. It's good for your mental health, and to have productive activities, right? And so
Accomplishments.
accomplishments, people like to feel like they're doing something, right? Doing something helpful, meaningful, and it's so I work with people, and there are stereotypes. Oh, they can't, they're because they have this, that, they can't work, or they can't do this or that, and or they can't exercise. And I would say no. I mean, do you need to be careful? If you're going to exercise, if you have cardiovascular illness or something, you check with your doctor and
Yeah,
make
of
sure you do
course.
it gradually. But you don't want to overdo it. But even modest exercise can be helpful.
Yeah. I mean, the only intervention that's been shown to improve the rate of recovery from a concussion is subthreshold aerobic activity,
Yeah.
right? And I think they measure it at like 80% your max heart rate.
Yeah.
That's big, right? Especially when you're talking about, the potential component of mental health after a concussion, especially if you have a history of mental health issues. So
We need to get more trainers or coaches out there, right?
I agree. What are the gaps in mental health care right now? What are the biggest gaps in mental health care? So in 2020, among the 52.9 million adults with any mental health illness, 24.3 million, or only 46%, received mental health services in the past year.
Yes.
Access, is that a huge gap?
There are two gaps. One is access and one is effectiveness. So access is, as you say, an enormous gap. Those people that get no treatment, no depression treatment, our treatments we have available work very well in that population. So there have been studies that showing, for instance, there's a Partners in Care study, when you reach out to people where they are, which is usually around primary care, for example. Everyone goes into primary care if they're not feeling well. With depression, most people are seen there. If you reach out to if you create resources in primary care to get those people treatment and improve access, that really works. That's called collaborative care, or there's various ways at it. Or to other specialties, like if you can also get people like neurologists or whatever, to get them to, do some brief assessment or something, a referral treatment, that kind of thing. That is really important for access, or for community centers, again, for reaching people who may have not great. So there's also, people with serious mental illness may not be well engaged in primary care. We've done work to try to improve that. People of color may be in communities where they don't have easy access to primary care. How do you, so that's sort of the access problem. The other problem is, once you identify people, what are the resources, right? So, I mean, primary care doc or most people, many people can prescribe a medication. So, I mean, I don't know, you may prescribe an antidepressant medication. Primary care doctors may prescribe one. But, again, therapy, how do we get people therapy? The other challenge we face is that while our treatments do work for mental health conditions, they don't work that well. There are some people that they work fully for, but there are many people who they just don't work for.
What's the proportion, would you say, off the top of your head, that it does not work for?
That's an interesting. We have all these people. We've done studies where, like for depression, for example, so in depression, the people that it's not working for are the people with persistent depression. So they're the ones who depression is in many or the majority of instances time limited. And again, it's hard to get these numbers because, so depression in the majority of people over like a year or something will get better, with or without treatment, gets better quicker with treatment. But there is some percentage, whatever it is, and, something like, there's like a couple percent in the United States, something like that, of people that have persistent depression. So those are the ones who it's not getting better for, who are either they're not getting treatment, which is a substantial number, or many of them are getting treatment, and our treatments just aren't fully effective. Like the medications and stuff. There are, how many people do the medications work for? About 3/4. It's hard to do these studies now because the medications are almost in the water supply. I mean, it's sort of so easy to get them.
Right.
But almost everyone's been exposed.
You got to say that was a joke because the conspiracy theorists out there will believe you.
Yeah, right.
Okay.
No, it's not. Right. We're not talking fluoride here.
Right.
So, it's like depression medication. So they could almost make them over the counter. But the research suggests about 3/4 of people with medication treatment and some counseling will get better, but that leaves about 1/4 where you need something else.
That's that's a large number.
Yep.
Let's talk about that something else. I gotta ask, what do you think about psychedelics for mental health issues?
So psychedelics are the most, of course the last, 60, 70 years have been remarkable for development of medications for mental health, right? Mental illness. It's hard to remember, but back before like 1950, 1960, there were no medications for psychiatric treatment. The past decades have seen classes, like the antidepressants and so forth. The past 20 years, 10 years or more, there's really been nothing new. Right. So, really since like Prozac, when there's widespread use, a lot of new antidepressant medications, they're pretty much the same as the old ones. So, in most people, psychedelics are exciting because it's a new class of pharmacologic treatment that shows a lot of potential for like PTSD and particularly, and some other, in research studies, we're going to probably see them available by prescription in the next year or two, some of them.
Really?
Yeah.
Which one?
I think the ones that are being furthest along in the pipeline are like psilocybin and ecstasy.
Yeah.
MDMA and psilocybin.
Yeah, the study in PTSD patients was pretty striking. The one
Yeah,
for MDMA.
when you consider how refractory PTSD is to treatment. I mean, those of us that have worked in the VA with PTSD, it's a tough illness to treat.
Yep.
It just doesn't. Medications, for example, do not work.
And it's so functionally debilitating.
Yeah, functionally debilitating. Medications just small, you know what I mean? Just
Right.
not effective treatment.
Yeah.
And so the chance, the idea of having something like it. Now, having said that, when the way psychedelics are being used now is in psychedelic-assisted psychotherapy. So they're not, there's no one suggesting they should be used on their own.
Right. You're not doing MDMA, going to a concert,
Right.
and assuming your PTSD is going to get any better.
Exactly.
Right. Yeah.
Yeah. So now, again, it's going to be the rub is going to be the psychotherapy part of that.
Mm-hmm.
Who's going to be with people? What is the counseling they're going to get? Are we going to have the resources to provide psychotherapy to people to go with the psychedelics. But, we need, for like PTSD, we really need effective treatments for PTSD.
Yeah. I mean, and you've kind of alluded to it before, the fact that like just a sheer work capacity to be able to supply therapy and all the needs for, the mental health crisis, it's just like really limited, right? And then, the studies that are being done right now with psychedelics, it incorporates a lot of therapy with a lot of time and resources. And I think some even have 2 therapists in one room. How sustainable is that for, all these mental health issues, right?
Yeah, I mean, it's sustainable if we're willing to build the workforce to do it.
Yeah.
And provide the insurance and the resources to make it available to people across the board, people with Medicaid, Medicare, private insurance. Is it theoretically possible? Yes, but you just see so many examples, like organizations like Kaiser that they work hard to make. They're sort of, when you have healthcare organizations that assume responsibility for a population of patients, then they're obliged to provide mental health treatment, right? A la Kaiser.
Yeah.
So like UCLA is not particularly, we don't take care of populations of patients. So patients under the sort of traditional fee-for-service scenario in the United States, if they fall through the crack, they just fall through the cracks. If someone's out there and they want a psychiatrist but they can't find one, that's, it's sort of that's tough luck, right? But, hopefully, so if their organizations are responsible like Kaiser, then suddenly they have to actually work to create the resources and the capacity. And that's sort of where we're at.
Because when you say if there's a health system that is in charge of a population, the metrics by which they're seen as successful are population-based metrics, not whatever other metric is being used for like UCLA, right?
Both the metrics and also the access. So if you're a Kaiser patient and you want a therapist, you know exactly who to call. And you tell your Kaiser, get me a therapist, and it's their responsibility. If you tell like your private insurance company, I don't want to pick on any, Anthem or whatever, Cigna, they're going to give you a list of people and say, start calling. And,
Right.
you're going to call hundreds of people and, you may or may not find anyone.
Okay. So do you think it would be appropriate to transition sort of a health, and I'm sure there's like a lot of logistical nightmares with this, right? But like transitioning our populations to being cared for by like one big health system, right? Instead of like you said, all these like other insurance companies and for pay.
Well, I think that's where we're headed. That's sort of like value-based care or population-based care. Obamacare started that. Obamacare created all these sort of financial arrangements necessary to make that happen. Everyone, I think people thought it was going to happen sooner than it has. It's been, most people, I don't know what your insurance is, but my insurance, I'm not in an HMO, or anything, they don't know if we use that term anymore, but, whatever these organizations are. Yeah. I'm in a preferred provider organization. And so I think everyone thought that we would be there by now, and people still think we're going to be there in the future, but, it sure is. And under this administration, there's been somewhat, in Washington, D.C., somewhat more movement towards that. Under the last one, there was not. Okay. And I think it's just a little, do I think we'll get there? Yeah, but I'm not sure when.
Let's talk about access real quick. And access is a huge issue that our patients have, especially some of the retired guys, repetitive head impact history, dementia, CTE, right? At the same time, right, via, whether it's the NFL or whatever other healthcare provider, they're being asked to do a lot of things logistically that would be very difficult for like an average person, right? But you're asking someone with a dementia or their caregiver, right, to be able to do all these things, fly here, fly there. And it's just the expectation of these people is like, a lot more than what they're able to do. I'm sure you come across the same thing in serious mental illness, right? Like schizophrenia. Yeah. And I'm wondering, how can we improve the access to these people? I know I've seen, using like the telephone, right? And possibly incorporating technology into providing further access to these people. What do you think?
Yeah, I think it's a critically important issue. Like in the TBI issue, the VA has a network of TBI centers around the country, much as they have a network of PTSD centers. And I think that's sort of the way to go around access is to have, organizations that are responsible. So organizations like the VA, Kaiser, they're sort of, that the organization is responsible for making sure that you have the access that you need. Now, having said that, I mean, we have some, there is access that you need. Now, some sort of bright spots with access nationally recently, particularly around the pandemic with telehealth, right? So everything moved to telehealth. Everyone's comfortable with their Zoom meeting and stuff with their therapist or their doctor or whatever. And and that in psychiatry definitely helps because a lot of psychiatry can be done by video or live televideo. And that provides access to networks of people. The other thing that I think we can do that we haven't done enough is figuring out, well, there's a couple things. One is the workforce. In terms of the mental health workforce, as a society, we need to do better. It's easy for legislatures to say, well, you need to have a psychiatric visit within a week of, asking to be seen or something. But, when you look at organizations, they'll say, like, that's impossible because we just don't, there's just nobody, we just don't have those people. Right. So there's the workforce problem. That's training. It doesn't have to be just psychiatrists. We have psychologists, we got nurses, we got nurse practitioners, we got therapists. And so the advantage of technology is one that's just this sort of like network effect of, if you're in a rural area, the chances of having a psychiatrist are zero, or mental health professional are near zero. But you can get, through these interventions, you can get access to someone at a distance. And, so it also matches, sort of people and capacity. So that's good. The other thing that technology can do is it can augment, augment psychiatric treatment. And so both of these, we've seen sort of an explosion, right? So there's apps, there's tens of thousands of mental health apps out there. They purport to be able to help you, sort of provide you like quasi-psychiatric treatment. They probably don't call it treatment because the FDA would give them a hard time, but through the app or something.
Like prescribing medications or just
or
psychotherapy?
Therapy in particular.
Yeah. Okay.
Yeah. There are some areas of medications where it can be helpful, like medications for addiction, like buprenorphine and that kind of thing, but to really help with access. But in terms of, particularly counseling, but there's also this whole field of how can we make more of what we have? So, like therapy, can computers provide psychotherapy? And sort of this whole sort of machine learning thing about, now you can like have a interaction with a computer with machine learning and maybe you can't tell it's a person or not. I don't know if you've seen those kind of things that are developing.
Like actually replacing psychiatrists or psychologists
through... Yeah, this is sort of interesting. So, I don't think that's likely to happen in the near future. But you could, there's sort of, or these like chatbots and things, which of course are eminently frustrating. But there's also... right. If I wanted a chat bot, I would have asked for one.
If I'm in a mental health crisis, I'm going to talk to one of those chat boxes. That sounds terrible.
Yeah, exactly. Yeah. And so and there have been studies. You can like cognitive behavioral therapy. Can it be provided by computer or an app? Theoretically, yes, but in real practice, does it work? No, not so much, because people like having, it's more complicated than that, right? There's like the social connection with your therapist, the idea that someone's helping you, cares about you, is working with you. It's a very psychotherapy, are very complicated interpersonal interactions, and the computer cannot replace it. But the computers they could augment it. So they can provide content and stretch our sort of psychotherapy workforce so they can do a lot more with what they have.
Yeah. All right. So let's talk about two more things. Where is research in mental health headed? Where do you see that direction headed?
Yeah. So a lot of the most exciting research in psychiatry or mental health is what we refer to as sort of translational research now, which is sort of bench to bedside research. We know a tremendous amount now about the brain through genetics, imaging, and are learning more all the time. But the real question is, how does that impact, how do we get that to patients, to patient care, to treatment, to assessment and treatment? And that's the gap that we really have not made any progress, very little progress on in the past 20 years. I mean, in the past 20, 30 years, if you ask how are we treating psychiatry compared to then, it's kind of similar. I mean, there are some things that are new, like neuromodulation and so forth is new. So does that, helpful new? Yes.
And
yes.
by neuromodulation, you mean transcranial magnetic stimulation,
There's one of
for
them.
example.
Yeah, for example.
Okay.
Yeah. There are other ones too. So that's new. But, otherwise, fundamentally, it's sort of like the same thing. So I think a lot of the, where NIH and people are at is really trying to figure out how we can bring together, geneticists, people looking at brain circuits, brain imaging, along with treatment with clinicians and treatment professionals to try and actually impact these disorders.
Yeah, because ideally you would be able to find people that are predisposed genetically to a certain disease, and they have, and that reflects a certain increased circuitry in the brain, right? And then ideally you would also figure out what kind of medication or what kind of treatment would be most effective for that specific patient. So like really customizing treatment is what I've been hearing.
Right, exactly. So like, transcranial magnetic stimulation is the example. People are trying to understand, everyone's brain circuits are different, and so how can we characterize this person's brain circuit, and then how we know how to intervene to help them with their mood, that kind of thing.
Yeah.
And this, but the same kind of thing with medications, would it, also developing new treatments, new new psychotherapies, new rehabilitation, and just plain new treatments.
Yeah, absolutely. Is there anything that you want to share before we conclude this episode of the Brain Sport podcast?
It's been a pleasure to talk with you. This is a great topic. I think it's I'm always really heartened to hear when people are interested in talking about mental health and improving mental health and what we can do. And also, most of us, almost everyone in our society probably knows someone who has a psychiatric or mental health problem, whether it's themselves or a family member. It's just so common. And so the question is, what can we do to help? Yeah,
absolutely. Thanks for all the work you're doing. Thanks for coming on, joining us, and then talking about all of this great stuff. Mental health is brain health, and mental health is a big contributor in brain injury, so it's certainly very interested. Our program is very interested in it. But there's so much more to talk about, so I hope that you'd be willing to come back and talk to us a little bit more.
I love the topic.
All right, so do I. Awesome. Thank you, everyone, for joining UCLA Brain Sport Podcast with Dr. Alexander Young. Thank you so much for coming. If you guys have any questions or concerns, please email the email in the YouTube video description. If you have any questions for Dr. Young, email the email in the video description. It's not your email, it's a separate email, don't worry. And then maybe if it's okay with you, I can connect those questions and maybe be the middleman for that conversation.
Yeah, happy to.
All right, awesome. Thank you, everyone. Have a wonderful day. Thank you for joining us, but most importantly, stay safe and be well.